Today the topic is chronic total occlusion. So we'll try to cover in first class. Second class we'll go in detail about the steps of CTO wiring and etc. So the topic is of importance for great importance for theory exam also. These three questions have been asked in the past: approach to CTO intervention, retrograde approach CTO, and the re-entry devices of CTO. These three questions have been asked in cohorts so far. It's a big topic. There are actually separate books for CTO itself, apart from the intervention cardiology books. CTO itself is a big topic, and there are several books for dealing that. So, this presentation I have mostly concentrated on this book by Brilakis and his YouTube videos. And several websites also give more information about CTO management, that is Progress CTO and CTOmanual.org. And guideline also 2019 circulation has published a general principle CTO thing as a review, state of the review article. So coming to the topic proper, how does a CTO look like on an angio? What is CTO? So this is a angiogram of a normal RCA, right coronary artery. So this is a normal anatomy of the RCA when we after revascularization. So during CTO it will look like a small stump, and the distal path we will not have any idea what is ahead of us. The distal vessel anatomy we will not be able to see. The only thing we can see is some collaterals that will be filling from the heterocoronary collaterals, that is from the other left side system will have some filling, and we may see a little of the distal part. So this is how a CTO looks like on an angio. So it's like walking in the dark with a lamp. That is, we will have a small lamp in our hand. We cannot see what is the path ahead. So each step we move, we will be able to get a little vision. So the long vision, we cannot see the path. So definition of CTO. CTO is defined as coronary occlusion, total occlusion. So this coronary occlusion can be total and subtotal. In total occlusion, there is no antegrade flow. It is totally cut off. Whereas in subtotal, there may be faint antegrade for filling. So chronic total occlusion is total occlusion with the duration characteristic. That is, if the duration is expected to be 3 or more months, then we can term it as a chronic total occlusion, or a newly documented occlusion not attributable to a similarly recent ischemic event. So these two are coming under the definition of a CTO. This is from Brilakis. This is from Topol, sir. This definition. This definition is from Topol. Actually, Topol, that Brilakis book, video, even guideline, recent some review articles also.
Conventionally, it is 3 months. In between, people used to say it takes to 1 month. So I just wanted the reference.
Yes. This is from Topol. Topol gives 3 months or more. So how do we diagnose CTO? So we see a total occlusion. How do we know whether it's chronic or not? Mainly we can say it by the presence of collaterals. And also if we examine closely, if there is on the CTO this thing, if we find some evidence of calcification also, we can say that probably it could be a CTO. Can differentiate versus an acute occlusion. In acute occlusion, probably we may see a thrombus containing lesion, etc., and that much collaterals will not be formed, so that we can diagnose probably an acute event. So what are the stages of a CTO formation? So here we can see that a vessel is getting occluded. So the plaque grows distally, and the proximal growth of the plaque may not occur. Here we can see that the plaque is growing a little, and here it is having a cutoff because the blood is flowing into the side branch. So the proximal growth may get stopped, whereas the distal growth may progress. And what happens distally is because there is no flow distally because of the total occlusion. So a collateral flow may occur from the contralateral vessel. So this is a collateral flow may be formed, and in the later stage, that is the last stage, there is a phenomenon called as negative remodeling. That is, here we can appreciate the size of this thing, it is little bulkier, whereas this is become small and negative remodeling is occurring. And along with that, there can be dystrophic calcification, that is calcium which is present is deposited in a vague manner along the entire length of the CTO. So dystrophic calcification, negative remodeling, collateral flow, and the proximal plaque stop, all these are features of a CTO. So on a cross section, how does it look like on a CTO? Like this is a normal artery, whereas on cross section we can see that there is a organized thrombi with the calcification. All these white areas are the calcification, and all it will be hard and all. So differentiating CTO versus a subtotal occlusion. I told earlier that CTO there will be no the antegrade flow, there will be collaterals present, whereas in a subtotal there will be antegrade flow, faint antegrade flow will be present, and there will be a small channel that will allow the antegrade flow. So on a histopathological examination of a CTO, what are the features? Generally, if we see that, if we think that when a vessel is occluded, we may expect that the vessel get necrosed, on all the architecture of the vessel wall itself get disrupted. But in a CTO, that doesn't happen. The entire wall architecture anatomy is maintained, including the intima, media, and the adventitia. So the anatomy of the vessel wall is preserved even though the blood flow is cut off. This is probably because of the vessel wall gets its continuous supply through the vasa vasorum. So vessel architecture is preserved, and this preservation of the vessel architecture will favor us that we can revascularize the vessel again. So we can see that the intima, media, everything is preserved in a histopathology. And on a gross specimen, we may see that the negative remodeling. This is the area of the CTO. This is the LMCA, circ and LED. So negative remodeling is present. That is the area where that it is become smaller. Then when we subject it to an angio, we can see that there is dystrophic calcification, calcium deposits present there. So what are the indications for revascularization of a CTO? We see a CTO, the decision whether to revascularize or not. It's not like all occlusions we have to open it up, because it's not like that. Even when we are opening it up, unwanted this thing, it may even become hazardous. That is
pathology proximal cap
അത് വരുന്നുണ്ട്. അത് ആൻജിയോഗ്രാമിൽ ഡിസ്ക്രൈബ് ചെയ്യുന്ന ആ ഏരിയയിൽ പോസ്റ്റമൽ ക്യാപ്പ് ഒക്കെ പറയുന്നുണ്ട്. പ്രോക്സിമൽ ക്യാപ്പ് എക്സ്ട്രാസെല്ലുലാർ മാട്രിക്സ് ഇൻ
extracellular matrix വെച്ചാണ്
proximal cap. Okay.
That is harder than the rest of the CTO. The remaining gap
Okay.
of fluid segment
Will be difficult to enter.
that is very
Why?
difficult.
Because of the difficulty, we need that CTO wire, special
There
CTO.
can be micro channels. Micro channel is always a elusive thing. You will think micro channel easy to go in. The problem is micro channel can be tortuous, or it can just end somewhere,
Yes.
end some plane, and then if you push through, it will just give you a small access into the lesion.
Yes.
So thinking micro channel, then you can pass the wire easily and you can take it. That's not the.
So the main indication or the key indication for revascularization of CTO is that when the patient has an occluded CTO, occluded vessel with symptoms. That is, person is having persistent angina. So if the patient is symptomatic, then we have to think that is the main key indication for opening up a CTO. That is, despite maximum medical therapy, still patient is having symptoms. In such cases, the revascularization is indicated. So in such cases, when we open up a CTO, patient will have improved angina, the exercise capacity will be improved, and the quality of life will be improved. So in that case, we have to open up a CTO. So when we are considering to open up a CTO, there are very factors which have to consider before opening up a CTO. One is the patient-related factors, significant symptoms I told already. Then whether there is an LV dysfunction, the extent of LV dysfunction with a viable myocardium is present or not. Then comorbidities and general condition, the renal function, because CTO is a long procedure, requires lot of dye. Up to 400 ml is the limit. At 400 ml of dye, we have to stop the CTO procedure. So renal function we have to consider. Then lesion specific factors, this in detail will whether it's single vessel or multi-vessel, distal diameter of the vessel, and whether it's a main branch or a main vessel or a branch. Then operator dependent factor is exposure. This is very important, that is the radiation exposure will be very high when we are doing a CTO procedure. Patient may even get a radiation induced necrosis and all. After the procedure is over, we may find that the back and all, patient will be having a radiation induced injury. Then the experience of the operator is very important. More the experience, the better, and the high chance of opening up the CTO. Then enthusiasm of the CTO operator, the energy, because it is a time taking process, we get fatigue during the procedure. More fatigue, the main this thing is wiring and ballooning. By the time we finish the wiring and ballooning, we will be totally fatigued. Then the stenting process, usually it will be quickly will be done. So the energy is important, you need an assistant and all. Then emotions, then factors related to the people around. Radiation, very important. Then colleagues, that is availability of a colleague around who is free to help you in needed. That is, if you are not able to wire the CTO lesion and all, you may need someone to help you at that time. Then lab time. CTO is time-taking process, so arrange the amongst the other regular cases, we have to make time for the CTO procedure, and according to others' convenience. So financial also, it will be little costly. So patient rated and hospital rated, allowing the use of costly hardware. Hardware also is very important, because more amount of hardware, various CTO special equipments are needed, wire, balloon, everything, and the catheter, everything are different. So the general approach is a patient with a CTO. Just first we have to assess whether it's.
Previously, CTO at one point it is said is that if you revascularize, open up the CTO and establish flow, this may serve as a conduit for another part or coronary artery which may occlude in the future. This may supply collateral to that. Justification.
Okay.
So many people are
multi-vessel
because that
CTO got
vessel is open and the silicon LED suddenly got occluded in the RCA or revascularized. The LED is occluded and CTO already was there in RCA. What is the chance for the patient?
No chances. So the general approach is a patient with CTO, if is symptomatic, then you have to consider revascularization. And revascularization, if the prior CABG was done, then there is no way, you have to proceed directly with the PCI. That is, even the CABG graft itself can be used for a rewiring and all. So you have to directly go for it. But otherwise, if it is not no CABG done first time, you have to assess the other factors, like how extent is the amount of lesion, is it a big territory is involved, single vessel or multi vessel. Then based on that, we have to go for a PCI. If it's a surgical candidate, then we can opt for a CAPG. If it's not symptomatic, continue with the medical therapy. So this is just the general approach how we have to say. So should I do it or should not do it? Should not do it. Another graph showing the benefit. If it's benefit symptoms, if the ischemic burden is high, myocardial function is good, we have to this thing. Then the likelihood of success is that is the difficulty. Difficulty is assessed by various scoring systems that will come in detail. So based on that scoring system, we have to assess whether its probable success rate is not. That is how difficult this thing it will be, whether we can wire the lesion or not. Actually, the main hurdle we have to cross is wiring the lesion. Once you are wired, almost 50% is done, and then the rest will be should be easy. Then the risk, that is, we can assess the complication risk by a progress CTO complication score. Whether if that scoring is high, also we can make a decision whether to do or not. And the long-term risk also. There is ISR, stent thrombus, etc. If all these factors we have to consider. So how difficult is it to do? So that is based on scoring systems. There are many scoring systems. The most important is the CTO score or the Japan CTO scoring, that will predict the difficulty for the CTO intervention. So it predicts the likelihood of successful wire crossing within 30 minutes of starting the procedure. So this is the JCTO score. It is based on 5 factors. That is, one is the lesion, whether the proximal cap is tapered or if it's blunt. So if it's blunt, we give a score of 1. If it's tapered, we give a score of 0. And if there is significant calcification, we give a score of 1 and otherwise 0. Then the angle that the CTO makes with the distal part of the vessel, if we are able to visible on a via the collateral. So suppose this is the RCA and it's terminating here and the distal area is here. So that angle which makes. So if that angle is more than 45, we can give it a score of 1. Less, we give a 0. Then the occlusion length, that is, if it's a long CTO occlusion, that is, if it's more than 20 mm, we give a score of 1. Then if it's a failed CTA previously and we are doing it for the second time, there also we give a score of 1. So based on these 5 factors, and if the score is coming as more than 3, it means that it's a very difficult lesion. And if it's 0, it's a easy, 1 intermediate, like that. So that is the GCTO scoring for assessing the difficulty before we decide about this thing. So what does the score imply to us? It just means that if we are getting a score of 0 to 1, even a beginner operator can attempt. That is, we can that score we can use it if it's a beginner, intermediate, or an advanced operator. An advanced operator can attempt to do a CTO with a score of more than 3. So in that way we can this thing. So the learning phase, initial phase, score is 0 to 1, we can attempt a CTO. So there are 4 stages for the operator. There are 4 stages in the learning of CTO. That is, the operator initially will not jump and going to do all the advanced this thing. That is the retrograde wiring and all. The details will come. So initially, CTO wiring, it's like there are 4 basic types of wiring. That is antegrade wiring, antegrade dissection wiring, then the retrograde wiring, and the retrograde dissection wiring. These are the 4 essential wiring steps. So as we go 1, 2, 3, 4, the difficulty increases. So initially in the stage 1, the operator skill initially will go for antegrade wiring only. Then later he may, when he achieves more experience, antegrade dissection re-entry. Then later retrograde via the collaterals, and later retrograde via the retrograde column and the dissection. Then finally is the stage 4 is where he can attempt to do even with the epicardial collaterals. So the collateral details will be discussing. Collateral details also will be discussing. That is not retrograde wiring. Not every collaterals we can attempt easily. There are various types of collateral. That is septal collateral, CABJ collateral. Then the least preferred collateral is the epicardial coronary collateral. So all the details will come. So the stage of the operator itself is graded. That is, not every CTO a beginner can do. So this is there are various other scorings other than the JCTO, that is the Japan CTO score. There are more scoring systems based on basic parameters are almost the same. That is the progress CTO score. So this looks at the proximal cap ambiguity. Proximal cap ambiguity is like the we see a CTO. So the proximal area of the CTO, whether that proximal cap, whether that is clearly visible, whether it's blunt or we see it clearly, or if it's ambiguous means it will be like wavy or distal like. So we will not know where to pass the wire after this thing. The point of entry of the wire will be very ambiguous. So that is proximal cap ambiguity.
Proximal cap ambiguous on the retrograde approach side to go on.
Point of view.
Not go on. It's only one point.
Only one point.
Different points are there, but it is one of the score.
No. Then based on the presence of collaterals, then based on the tortuosity, the more tortuous it will be difficult. And when we are doing a circumflex CTO, so circumflex CTO is given 1 point. That is not there in the Japan CTO score. So this is another scoring system. So there is a website called progresscto.org. So we see a patient, immediately we can go to mobile and if we click all these points and this thing, and they will get the score directly. All the scores we will get directly in this website. JCTO score, progress CTO score, everything. And it will give the probability of how it is possible to we are succeeding or not. The probability that it may succeed. So ഇത് വേറൊരു സ്കോറാണ്. ഇത് CL സ്കോർ.
JCTO അല്ലേ നമ്മൾ commonly use ചെയ്യുന്നത്?
Yes sir, commonly JCTO.
JCTO യിൽ ഒരു പോയിന്റ് വന്നാൽ തന്നെ chance comes down by 40%. Yes. Even if there is one unfavorable, practically when we see an angio with a cath lab, there is one point. You are calling the bystander. You cannot simply say 80% success rate. Normally our PCA rate is 99% because it is a CTO, it is 80% and the parameter. So that much it is low. Not that we should not do. I'm just 58%. This has been developed by centers who are routinely doing CTO.
That has been validated also.
Validated.
Japanese score is validated in Canadian CTO center.
So 2 points on the 70% failure rate now. Only 30% success rate.
Maybe we can tell the failure rate in the first attempt. Even if it's failed CTO, we can try. We can retry after 2 to 4 weeks.
One more score. There is an additional
point will come in JCT.
That is also. Score will be less.
People who do more CTOs will be more confident. They may not take it. We have to be honest. We are not a very deep CTO center, so our approach will be slightly different because we may be influenced by this data. We may tell in some cases that vessel is already occluded. There are good collaterals. Patient has no symptoms, so no need to do. But another patient with pre-vessel disease with a CTO, there is CTO. Definitely we will send for CAB. So we will be more pro-grafting compared to PCS. We also have our biases to understand everything in context. Then the risk is also there. This is not compared to a CABG putting graft for a CTO. The risk is very high.
What is the usual that you must be coming into?
Complication.
What is the complication rate?
Very nice.
And what is the class of indication for attempting in CTO?
Class of indication. Class. I'm okay.
So is it a class 1 indication or is it like
2A
comes less than that? So whatever the indication comes to only class 2A.
Class 2A.
Not above that, right?
Even if symptomatic.
Even if symptomatic. It's not a class 1 indication. We are many things which are class 1 we are not doing straight. So that also you have to take into account.
So to make things more complicated, there are other scoring systems also. We have discussed the JCTO and the progress CTO. Another scoring CL and ORA scoring systems. We are not discussing here. So coming to reading an angiogram when we are deciding whether to do a CTO or not. This is a very important aspect. That is how to read the CTO lesion. So it is the most important factor in procedural success. That is, it will help in deciding the selection of the patient, selecting what strategy we have to go. That is the antegrade wiring, retrograde wiring, dissection and wiring, etc. Selection of the guide catheter and the guide wire. All these are important so that's why reading the angio for a CTO is very important. So what are the points we have to see in the angiogram? There will be micro channels. I'll discuss that. Entry point, exit angle, side branch, island inside the occlusion. Inside the occlusion there may be some islands. Then calcium, presence of the dystrophic calcium. Then tortuosity of the occluded segments. That is that we will not be able to see on a routine angiogram because the vessel is occluded and we cannot know what is
unless we see calcium.
Unless we see calcium. So we cannot know what is lying distally. So in such cases a CT angiogram will be helpful in showing the distal path, whether it's tortuous or not. CT multi-slice CT may help in such scenario. So this is the CTO. The 4 key angiogram panels you have to see is, so this is like CTO of the right coronary artery, and this is the LAD with LAD supplying collaterals to the right the CTO lesion. So the parameter is the proximal cap. This is the proximal cap. So whether this is ambiguous or not. Here we can see that we can see it properly. It can be either a flat proximal cap or a like this. Tapered. Then the length of this CTO lesion. The more longer it is, the more difficult the this thing will be. Then the distal vessel anatomy, whether we are able to see on a double injection. Double injection means will come in detail. We'll be injecting both the right coronary as well as the left coronary simultaneously. Then with this collateral flow, we'll be able to see the distal part of the vessel as well as this proximal. So that in that way we can see. So the proximal cap and the proximal vessel, the length of the lesion and the quality of the lesion, whether it's calcified or not, then quality of the distal target vessel and collateral circulation. So this collaterals also we will go into this detail about the discussion, that is whether it's a good collateral or not, the angle with which this collateral makes with that, whether we can pass a wire, how easily we can pass, all those parameters we'll be discussing. So the same thing I told, another picture, proximal cap, whether it's ambiguous or clear, it's tapered or blunt, side branches are there and calcification. This is a collateral thing. So collaterals we have to assess properly whether it is which is the collateral that is supplying. Actually there are various sources of collaterals. So suppose if the RCA is occluded like this, there can be a ipsilateral septal collaterals from the same RCA itself. There can be ipsilateral epicardial collaterals, or the most important is from the other coronary tree we may get a contralateral septal collaterals. So this septal collaterals are very useful, and this is the one most preferred for CTO retrograde variant, septal collaterals. And there can be also epicardial contralateral epicardial collaterals. So epicardial collaterals will be small caliber in length and may not be that useful. They are the last preferred collaterals. The most preferred is septal collaterals. And the other collateral we may get is the patient after a CABG, patients having a CTO, then that graft itself can give collaterals to the distal vessel. So these are the sources of the collaterals.
What does the septal collateral mean? What does the term indicate? Septal collateral means?
Septal collateral means why be straight and large vessel.
Not always be straight.
Like just like the LED septal.
That is what.
Just like the LED septal.
There are branches.
Yeah, just got a course through the
That is why it is the safest. That is material, if you go through epicardial collateral, you will produce gangrene if you cooperate. It is relatively more safe because the septum.
Inside the septum. Going through the septum. Not regular septum. So even if you perforate, it will produce a intramyocardial hematoma. Or if it is rupturing, it will be rupturing into a chamber rather than into the epicardium.
Pericardium. Okay.
So the tamponade
risk is less if we choose a septal collateral.
Collateral classification point.
So when we are assessing the collateral, we have to see what collateral is supplying to the distal vessel, whether it's septal, bypass graft or epicardial. Septal is most preferred. Then the size of the septal collateral, that Werner classification is there to determine the size that we are coming. Then whether it's tortuous or not.
The collateral
classification is rentropil.
It is size. അതല്ലേ റെൻട്രോപ്പിന്റെ പറയുന്നില്ലേ, അതാ ഞാൻ ഉദ്ദേശിച്ചത് മുമ്പ് ഞാൻ
collateral
RENTROP 0 1 2 3.
Yes. So coming to tortuosity, whether it's tortuous or not, the more straight the collateral, the better, so that we can put a retrograde very easily. Then dominance, that is from which dominant, whether it's coming from a dominant vessel or not. That is, during the procedure, if it gets occluded, whether it will be a risk for a bigger territory or not. So then the angle at which the location of entry, that is the angle at which it makes with the distal dressing, this we will come, whether it's a favorable collateral or unfavorable collateral. So I told earlier that bypass collateral and the septal collateral are more better compared to a epicardial collateral, because septal collaterals are more preferred because perforation risk, everything is less, and dilatation also we can this thing is bypass and septal, whereas epicardial we cannot dilate because of the small caliber. So this is a Werner classification of collateral. So this is the LED, this thing giving collateral to the RCA. So this is the other this thing. So we can see that the collaterals are non-continuous. That is, collaterals are just started forming, but they have not touched each other. So that is a CCO 0. That is non-continuous. Then continuous but less than 0.4 mm. That is 1. Then more than 4 mm is 2, and more than 1 mm for 0.4 mm is 2, and more than 1 mm is 3. So that is a Werner classification of the collateral. Just a pictorial representation. These collaterals are the 0, this thing not continuous, that is 0. Then thread like mild continuity is there 1, and connection is there with more than 0.4, that is 2. So coming to collaterals, we should decide whether it's favorable or not, and there are various factors to decide whether it's favorable or not. So
zero, no flow of the distal segment. Zero, that is one is you're filling the side branch, and two is you're filling the main branch through the collateral partially. Three is fully you can see the distal vessel.
This
So very clearly through the collateral filling the distal. 0, 1, 2.
0.
Zero the collateral filling
Nothing. There is no
nothing is
visualization of the
very
distal
good.
segment.
So this column shows all the collaterals are favorable and this is unfavorable. So one is whether there is a proximal disease or not. That is, we may have to go for a retrograde wiring, we have to pass a wire through this. So in this is a case of unfavorable where there is a disease in the proximal segment. So we will be having difficulty in passing wire through this unfavorable segment. Whereas favorable, we can easily pass through this because of no disease. Then the angle with which this collateral, this is the collateral actually we are discussing here and now. So the angle with which the collateral makes with it, if it's more than 90, it is easy to pass the wire. Whereas if it's making an acute angle, we may find difficulty to pass the wire through this acute angle. Then the size, if it's big, easy to pass, small, difficult to pass the wire. Then if it's tortuous, easy, it is favorable. Because if it's not tortuous, it is easy. But if it's tortuous, we cannot pass the wire. Then the bifurcation, if the collateral is bifurcating variously like this, it is difficult. If it's no bifurcation, if it's straight, it is favorable. Then if there are more collaterals, it is more favorable. Why? Because if we are not able to pass a wire through one, we can pull it back and try it through the other. Whereas if it's one, it is not that favorable. And the angle, the exit angle, this is the exit angle, that is the collateral coming and connecting with the RCA distal branch. So this angle also, if it's more than 90, it is more favorable. Whereas if it's becoming more acute, you'll have to pass a wire and then come back. So that turning the wire in that acute angle will be difficult. And the exit location, if the distal cap from the point to the distal cap, if the distance is less than 10 mm, it is favorable. If it's more, it is less favorable because we have to pass the wire and then we have to travel still more to reach the distal cap. So all these things will help us determining whether the collateral, when we are deciding about retrograde wiring, these factors we have to consider in the angiogram. It will assess us how difficult it will be. So the another important thing is this collaterals can be dynamic. So before the plasty you see some collateral, the vessel, the size of the collateral, all these things. But after the plasty it can be different. So this is a patient with before there's a lesion at the LAD with various collaterals filling from the RCA. These collaterals are being filled from the RCA. But after this rending, we can see that the collaterals flow, everything has diminished and the collateral size has come down. That is because antegrade flow has come better from the LAD, so that retrograde flow from the RCA stuff. So the collaterals can be dynamic. Then important thing is contralateral injection or dual injection. This is very important and important step in the CTO. This thing we have to do it routinely. Contralateral injection, dual injection means you have to simultaneously inject from the left coronary ostium as well as the right coronary ostium. So it will help us in detecting the length of the distal vessel, the occlusion length, and the costal collaterals. There is a tip to reduce the dye because of this, because we know that dye will be more this thing. So we should try to use a suppose this is a RCA lesion and we want to do a dual injection. So we should not inject from the ostium with a regular catheter. Instead, we pass a micro catheter through the ostium and keep it near the collateral, and then we inject, means that much dye we can save. Selectively we inject into the collateral. So രണ്ട് ആക്സസ് വരുന്നുണ്ട്. അല്ല ആക്സസ് access I'm coming. Access I'm coming. We may need more access. Even triple access will be required. അത് 300 ഉം 320 അത് വരുന്നുണ്ട് സർ. ACT what is the thing? ACT value ആണ്. So
in between a stage you may reach when you don't need the then you can usually for better support CTO guide will be putting towards the tomorrow. So for contrast usually the right radius.
Contrast injection we can even do with one axis that I am showing. So this is the dual injection. So what we do is we engage both the coronary ostium. First we inject the donor vessel. So if this is the CTO vessel, this is the LED we call as the donor vessel and the RCA we call as the CTO vessel. So first we inject the donor vessel, then we have to wait for the dye to reach the collateral, then only we inject the CTO vessel. It's not simultaneously injecting. Initially we inject donor, and when the dye reaches at that point we inject the CTO vessel, and we have to give cine until the contrast clears. So this is a video showing the dual injection. Here we can see that there is a catheter in the left coronary ostium as well as a RCA catheter in the right coronary ostium, and we are injecting initially in the left system, and that is filling the collateral, and when at that time we give the right injection. So we from the both direction we see, and we can access the lesion. So access we can even do it with a single access also dual injection, that is we use 2 4 French diagnostic catheter, 2 4 French through a 8 French sheath. We can use it like this also, or we can go for a multiple access also, that the access will come in detail. So what are the benefits?
How can we do the angioplasty through a diagnostic catheter? Actually, if you are proceeding with an angioplasty, you have to take a French catheter. This
is like before the CTO decision, we are just doing only the angio. We are not decided that whether to do the CTO or not. But before doing, for planning how to assess the lesion, we can even do it with a single access site and do a dual injection.
If you are planning a CTO, or if you are concerned about CTO in future, you have to take angio in such a way that all the information is available to the CTO.
Maybe for that maybe we do like this. But sir, ഇത് നമ്മൾ H ഷീറ്റിൽ 4 ഇടുമ്പോൾ ഇത് ലീക്ക് വരത്തില്ല അല്ലേ ഇതിനിടയിൽ? രണ്ടെണ്ണം ഇടുമ്പോഴും രണ്ടും റൗണ്ട് അല്ലേ, അതിന്റെ ഇടയിൽ ഗ്യാപ്പ് വരും. So some leak is expected.
Obviously actually you have to go to somewhere.
Mostly somewhere. And whether we can manipulate one while keeping the other stationary. ഒന്ന് വലിക്കുമ്പോൾ മറ്റൊന്നും കൂടെ വലിഞ്ഞു വരില്ലേ? So what are the benefits we get with the dual injection? That is, before the PCA and during the PCA we get separate information. So one is before the PCA, the thing we get is we get all the CTO characteristics of the lesion. That is, this is without this thing we see only the proximal cap, whereas with the dual injection we see that the proximal cap is clear. Without the dual injection we have no idea about the lesion length, the distal cap, the distal vessel or the collateral. With the dual injection we can see that the length of the lesion, distal cap is at the bifurcation. Here we have the picture is behind. Then distal vessel is good.
Distal vessel cap at bifurcation, or this is the distal cap.
Bifurcating.
This is the
Okay.
This is the length. Immediately bifurcation. At the cap there is a bifurcation.
Yes. So this is a CTO lesion, and we are getting more information about the CTO characteristic with the dual.
Short CTO ആണ്, പക്ഷേ bifurcation ആണ്.
So now before another thing is we get this micro channel information. That is, we are suppose
good presentation.
നാളെ കണ്ടില്ലേ?
തിങ്കളാഴ്ച നാളെ എല്ലാവരും ഉണ്ടോ? നിങ്ങളുണ്ടാവും. ആദ്യം മറ്റേ അവിടെ മറ്റൊരു ഭാഗത്ത് പോകും.
ഇതിപ്പോ 48 ആയി സാർ, 91 ഉണ്ട്.
ഇതിനകത്തൊക്കെ ലെങ്ത് എത്രയാണ്?
20 ആണ്.